Good afternoon and welcome to Facebook Live with Holy Cross Health. My name is Brenton Andrasic, Manager of Physician Alignment and Business Development at Holy Cross. Before we begin, I'd like to call your attention to a few ground rules that you'll see in the comments section. We encourage you to participate, but please keep any questions and comments general. We won't be discussing anyone's specific health situation in this public forum. If we can't get to every question today, we'll provide additional feedback through our website, or we can connect with you one-on-one through our program channels by phone or website. For those of you joining us today on Facebook, we thank you for being here and for taking an active role in your health. And we at Holy Cross are happy to be your partner in your health journey. Osteoarthritis is the most common joint disorder and form of arthritis in the United States, affecting more than 30 million adults, and that number is increasing with our aging population. Today we're here with Dr. Douglas Murphy, orthopedic surgeon and member of the Holy Cross Health Board of Directors, and Laura Collins, orthopedic surgery program coordinator for Holy Cross Health. Dr. Murphy, to start off, can you just tell us what is osteoarthritis, what causes it, and how does it differ from other forms of arthritis?
Sure. Thank you, Brendan. So osteoarthritis is generally referred to as wear and tear arthritis. It's from cumulative trauma over many, many years typically. It differs from other forms of arthritis, such as rheumatoid arthritis, arthritis associated with psoriasis, psoriatic arthritis, and other things that may have caused arthritis in the past, such as a previous infection, some people differentiate post-traumatic arthritis from plain osteoarthritis, but a lot of it is kind of overlaps. But generally speaking, it's arthritis that is caused by wear and tear, sometimes previous injuries, sometimes previous trauma, and or potentially surgery.
And Laura, could you tell us what are some of the areas of the body that osteoarthritis can affect?
So it's typically the weight-bearing joints that are affected by osteoarthritis. So as we age and our joints wear down, because cartilage tends to desiccate and wear down, and you can have bone rubbing on bone. So we're talking about your low back, we're talking about hips, knees, and sometimes osteoarthritis can also happen in your hands.
And what are some of the risk factors for developing this?
Age, obviously. I believe the statistic is 85% of people over the age of 65 have some form of osteoarthritis. Being female, women tend to have osteoarthritis more often than men. Being obese, overweight can certainly be a factor. Repetitive stress, so your work environment or a sports injury, can also add to the risk of developing osteoarthritis later in life. So even if the injury happened when you were younger, that can lead to that damage that tends towards osteoarthritis when you're older. So those are some of the risk factors.
I would just add that for a lot of people have questions about how much of arthritis is genetic. For osteoarthritis, wear and tear arthritis, not too much of it tends to be genetic. However, other things, again, obesity is the most common contributing factor, certainly in the United States. Obesity tends to run in families, whether it's to the extent it's genetic or not. I will say that for different joints, particularly for hip joints versus knee joints, which are the two most common ones we deal with, hip joints tend to be a higher percentage of people have some genetic component, possibly some, we call it a malformation or dysplasia. The term is generally mild dysplasia of your hip. So maybe your hip was not completely round when it was formed. It may take some years for that to develop. Most people still develop osteoarthritis in a dysplastic hip when they're in their 40s, 50s, 60s, or later. But some of that is a genetic condition.
And what are some of the conditions that might mimic osteoarthritis symptoms?
Well, again, it's a little bit specific for a particular joint. I will say for hip arthritis or hip pain as in general, we see a lot of people who have a severe bursitis, which is just inflammation of the bursa over the top of the hip joint or on the side of the hip joint. And that can mimic osteoarthritis. Many people come in and they think that they need a hip replacement, and they're very happy to be told that they don't. Because very often the pain is very similar in location. Generally speaking, it's a little bit different in its progression. So if people have osteoarthritis, one of the things that's very consistent is the more you're on the joint, the more you use the joint, the more it's going to hurt. And that tends to be pretty consistent, whereas bursitis, other issues tend to be sort of more sporadic.
Right, and related to that, figuring out what is the actual issue for the patient. Dr. Murphy, could you tell us a little bit more about how you go about diagnosing osteoarthritis?
Well, for most osteoarthritis, the basic test is still a plain X-ray, and that's where we start for 99% of people, I would say. We do other tests. It's not always necessary to get MRI scans or other scans to diagnose arthritis, particularly if it's more severe, particularly in hip joints, for instance. So basically, we start with an X-ray and progress from there. We rarely have to do other invasive tests such as diagnostic aspirations or removing fluid from the joint, things like that. But occasionally we do that as well to look for other causes, gout, Lyme disease, variety of things.
And so if you've gone through the diagnosis process, what sort of development of the disease could a patient expect to experience over the course of time?
That's about as varied as the patients themselves, so it goes everywhere. Again, most people have this idea that once they're told they have osteoarthritis, and again, not everyone who thinks they have it actually has it, but once they're told they have osteoarthritis, then everything else is just delaying until it's quote unquote time for surgery. Not all osteoarthritis even progresses. Many people never progress to where they need surgery. There's many things that we can do short of surgery. That's kind of what we're discussing a lot of today.
Absolutely. To that point, Laura, I was hoping that you could tell us a little bit about some non-surgical therapies that exist for managing osteoarthritis pain.
Sure. So I'm a physical therapist, so certainly referral to physical therapy can help. Osteoarthritis is something that can't be reversed, but we can certainly support. So if you are referred to physical therapy, we could work on strengthening. We can work on modalities to help pain and reduce inflammation, such as ultrasound or e-stim or heat and cold therapy. Even I think dry needling is in vogue at this point. Bracing, if you need an assistive device, we can help you learn how to use the assistive device appropriately when you need it. We have other things here at the hospital too that can help. We have a dedicated pain management center that also can assist. We have a nutrition counseling for people that need weight loss that's available. And we also have a lot of community wellness and fitness classes designed for joint care. So we have Better Bones classes, Senior Fit, Pilates, yoga, all kinds of resources that can help slow the progression of the osteoarthritis and hopefully delay or maybe even eliminate the need for surgery in the future.
And do you find that some of these non-surgical interventions work better for some joints as opposed to others?
I'm not sure if it's the particular joint or how progressed the osteoarthritis is. I mean, if there's a frank deformity because of the osteoarthritis, it's a little bit more difficult to treat. If it's early on and they're just having occasional symptoms or more mild form, then we can probably assist it in the more conservative measures.
So we had some questions come in from folks who pre-registered for the event today. So we're happy to field some of those questions. So Laura, I'm going to direct this one to you.
Sure.
Someone wrote in and said that they're having difficulty walking up the stairs, and even just walking 100 feet can be difficult. And they were told they must lose 60 pounds before you could have knee replacement. So the question is, what could this patient do for the osteoarthritis pain and lose weight when they're having difficulty walking?
Well, I think probably the nutrition counseling might be the first port of call for them. I know Julia Mutter in our community resource can assist with that. So maybe just even looking at the diet first and see if we can start that weight loss. Even a minimal weight loss can help joint pain. So start there. Certainly aquatic type of physical therapy, aquatic exercise can help get that exercise component and not have the weight bearing issues related to it. So, and also physical therapy, just trying to start out with physical therapy and seeing what they can do to support the joint, reduce the pain and inflammation while they're in the process of trying to lose the weight.
And I would just say that's actually a big topic, particularly for the last 5 or 10 years. I'll just limit this to more or less for knee arthritis because it does vary a little bit, but knee arthritis is where it's most common. So there's been a trend in the last 5 or 10 years to have a certain number, which is kind of arbitrary. We usually use what's called body mass index or BMI. So you can calculate your BMI online. There's a variety of places you can do it. It's your weight and your height according to a formula. So a lot of people will say that the results of a surgery, again, let's just stick with knee replacement, gets worse at higher BMI levels, and that's generally speaking true. However, it's not completely true. First of all, there's no one cutoff number. So people say, some hospitals have started to say they won't do surgery on people with a BMI over 40, for instance. We do not have that restriction here at Holy Cross. I don't think it's really supported scientifically. The two arguments are, number one, people with a higher BMI have a higher risk of complications at the time of surgery, which is true, but it's only for some complications, not every complication that there is. And then the other thing is that's important to know, BMI decreases the longevity of your knee implant. So an average knee implant in the United States, I tell everybody this, average knee implant will last for 20 years on average. If you're higher body mass index, it is slightly lower than that, but a lot of studies will show that it only goes down by 5 or 10%. The other thing that's important to know is if you look at patient satisfaction, it's every bit as high for people with a higher BMI. In fact, it's probably higher for the highest BMI people because they tend to have the worst arthritis. And then the third factor is some people simply have no option to lose weight because they simply can't exercise until they get their knee fixed. So the whole issue of requiring a certain weight or a certain BMI is actually a lot more controversial than some centers and facilities and physicians will make it sound.
So before we get further into the discussion about the actual surgical interventions available, Dr. Murphy, could you just tell me a little bit more about injections and what role they play in pre-surgical treatment?
Sure. So we do there's basically 3 types of injections that we do, we'll just go through them in order. Cortisone injections, quote unquote cortisone injections, which can be a variety of different types of cortisone, but they're basically standardized. They tend to be anti-inflammatory. They tend to be decreased pain. We tell people that they'll probably last about 3 months in any given joint. The other injections, which people generally refer to as gel injections, that's the most common term for it. We call them viscosupplementation injections. They have an active ingredient in the injection, which is generally hyaluronic acid or some form of hyaluronic acid. Those are designed to support the cartilage. There's also an anti-inflammatory effect. And they may last a little longer than cortisone injections. We typically expect that they will. However, I always tell people, if you're going to support the cartilage in your knee, you have to have some cartilage in your knee. So at the point where it's completely worn out, bone on bone, they tend to be less effective. And then the third type of injections, generally we refer to them as regenerative type injections, but they're PRP or platelet-rich plasma injections, stem cell injections, and a variety of other factors that can be injected. Typically, these are your own cells. PRP is just your own blood that's basically spun down, and we remove the red cells. These are designed to also be anti-inflammatory. They probably have a little bit better role in terms of supporting, again, cartilage that may still be there. They're also not necessarily for everyone. The issue of stem cell injections, I think, has probably been a little bit overblown and overplayed. That really has a fairly minor role to play in most treatment of osteoarthritis.
So we got quite a few questions that came in around this topic. So Dr. Murphy, I'd like to direct a few of these to you. So someone asked, if you already have bone on bone, is there any new treatment available that will work to eliminate pain instead of joint replacement?
Well, I always tell people that when I started in orthopedics in the mid-90s, we thought if you'd asked me by 2022, 2021, I guess we're not quite there yet, would we have some growth factors that you could put on there? And I always say, just like putting fertilizer on your lawn and having your grass grow back. And I would have thought that we would have had that by now in 1994. We still don't. Once cartilage has been essentially scraped off of the bone and you're looking at the bone underneath the cartilage, I always tell people what was in that cartilage was the actual cells that are making new cartilage. So it's kind of like it's like a raisin pudding. That's what I tell people. If you scoop out the raisin pudding, you scoop out the raisins and you scoop out the pudding. So the pudding is the cartilage. The raisins are the cells that are manufacturing the cartilage. So the problem is you lose them both. So you lose the capacity to regrow the cartilage at the same time you're losing the cartilage. And that's what makes it difficult to reverse. Now, I will say for bone-on-bone arthritis, again, mostly in knees, If it's in a very specific place in the knee and the rest of the knee is pretty good, we actually can do partial knee replacements, and we only replace the part that has the arthritis. So even if you have a bone-on-bone knee, if it's only in part of the knee, we can still do something short of doing a complete knee replacement for many, many, many people.
So we've covered quite a bit about non-surgical interventions and different things that patients can try prior to surgery. So let's talk a little bit about the actual surgeries now. So Dr. Murphy, in general, when would you say it's time for a patient to consider getting surgery?
So that's a very good question. Again, there's been a lot of research focusing on, what's the minimum age, what's the maximum age. Several things I always tell people, again, this is about your quality of life. It's not necessarily about your age. There is no such thing as too old for a knee replacement or hip replacement. Literally, we do people in their late 80s very routinely. The controversy is more on the younger side, if there's such a thing as too young. Again, the average knee replacement does last for 20 years. The average hip replacement in the United States probably lasts longer than that. So you really don't have to worry. In the majority of people, you do not worry about having the knee just wear out after it's replaced. Most people, once they have a knee replacement, the knee functions just fine. It increases their quality of life. It improves what they're able to do. And ultimately, when they pass away, their knee is going to go with them. So the vast majority of people, only about 15% of all joint replacements require repeat surgery. And that's across the board pretty much for any reason. That could be because the joint was wore out, because there was a fracture around it, because it got infected, et cetera, et cetera. So 85% of people who get a knee or hip replacement don't actually ever have any other surgery. It doesn't mean that every one of those functions perfectly. It doesn't mean that every person gets back the activity level that they really want or thought they would, but it's only about a 15% rate of surgery overall over the entire lifetime of that person or that joint.
And related to that point, we did get a question come in. Someone asked, if you had a knee replacement over 13 years ago and the pain in the knees is recurring, what are your options?
Well, I mean, that has to be a start by seeing an orthopedic surgeon and getting an x-ray and potentially doing other things. A big question with a lot of people whose knees are not functioning well now is, were they functioning well 2 years or 3 years or 5 years ago? So there's a big difference between a knee replacement that for some reason was never quite what you wanted versus a knee replacement that was great for 15 or 20 years and now has taken a turn for the worse. So that's kind of the distinction that we typically make, but that's something that just really has to be evaluated on a case-by-case basis.
And Dr. Murphy, one more viewer-submitted question for you. Someone asked, I need a hip and a knee replacement. Would this all take place at the same time, or would they be separate surgeries?
You do the hip first. That's one of the standard rules of orthopedics. If you do the knee replacement and you have a bad hip, it inhibits your rehab for the knee. If you do the hip replacement first, because a lot of hip pain is actually referred down to your knee. So if you have a hip replacement, it makes your hip feel better and your knee feel better. If you have a knee replacement with a bad hip, your hip doesn't feel better and it actually keeps you from rehabbing the knee. So we do the hip first. We rarely do them a hip and a knee at the same time on the same leg. We do bilateral hip replacements and knee replacements. So we can do both joints at one sitting in one surgery. It's more common for knees than for hips.
Thank you for answering all of those viewer questions, Dr. Murphy. Laura, I'd like to turn to you for a second. So I'd like for you to talk a little bit about how Holy Cross Health helps patients to prepare for their surgery.
Sure. So if you go to our website, holycrosshealth.org, and you just search Preparing for Surgery or Orthopedics, you can find our page. We have pre-recorded classes to help prepare for joint replacement. We have virtual classes. In 2022, we hope to get back to in-person classes, which is always great. We have hip and joint specific guides that they can download or save on their computer as a PDF. We have the ability, you can go on Preparing for Surgery and just get general information about preparing for surgery. All of our elective surgeries have COVID test before they have surgery. So there's a lot of information that you can discover in that preparation. We also do pre-op home safety. That's available with our Holy Cross Home Care and our discharge planner. is a social worker that is dedicated to our joint and spine patients. She calls everyone prior to surgery. We try and start that discharge planning before they come in, helping them prepare their home, making sure they have the right assistance at home, also that they have a smooth transition from hospital to home, and their recovery is trajectory instead of having bumps in the road, not knowing what to expect.
Could you talk a little bit as well about COVID precautions for surgical patients?
Sure. So one of the things that we do is we test everybody 1 to 2 days prior to elective surgery. We have all the COVID precautions in the hospital that we've had since March of 2020. So the physical distancing, everyone has to wear a mask in the hospital. So those are, everyone that's coming into the hospital has to be screened, whether you're an employee or a visitor or a patient. So we are on top of that to this day. So I assume we're going to continue these precaution measures until it's no longer needed. Correct.
They're never far away.
Never far away.
I just wanted to throw one other thing in there as far as preparation. So a lot of people, when you tell them they're going to have a joint replacement, they pick their surgery day, and then they sort of feel like they're on a conveyor belt, and they have to do all of these things, all in this order and whatever. And to some extent, that's true. We do have protocols and systems and standards for just about everything that we do, but almost all of that is based on some sort of scientific rationale. And it's very important to note that one of the things that improves your long-term result from your joint replacement is a lack of short-term complications. So if you go back and look, and again, I said only 15% of people ever need any surgery for their hip replacement for their lifetime, or the joint replacement. But if you look at, say, 5-year results from hip replacements, you get 95% effectiveness. If you could take every complication that occurred in the first 90 days and eliminate all of those complications, you'd get 98 and 99% effectiveness. So it's very important to eliminate those early complications. And the primary way we do that is by standardizing, systematizing, having standards that we enforce to make sure that people have their surgery as safely as possible. And then the other thing is rehab it as quickly as possible. And those two things are going to give you less short-term complications, and therefore you're going to have a better long-term result.
Okay.
So I think this is a good time for us to talk about the surgery itself. We've covered a lot of ground here, but Dr. Murphy, could you just describe the surgeries for osteoarthritis and some of the special equipment that we have available here at Holy Cross Health?
Sure. So I guess let's just do with hip and knees for now. We also do shoulder replacements, and then there's elbows and ankles, and you name it. But let's just start with hips and knees. So with hips, the big thing, I guess, that's not even new anymore, but the buzzword has always been minimally invasive surgery. I always tell people minimally invasive is in the eye of the beholder. There's no one number or one standard or one length of your incision. However, for hip surgery, we typically do surgery we call it an anterior approach. It requires a special table, of which we have 2 of them, plus a backup. And typically that's done with a patient supine, whereas the quote-unquote older hip surgery is done with a patient on their side. 2 big advantages to that: because the patient is basically in a stable position, we can use the x-ray machine and take accurate measurements. You can take x-rays obviously during the surgery whenever you want, but the question is, can you really rely on the measurements? So with the anterior approaches, because the patients are in a standard position on a standardized table, we can look at the x-rays, we can measure things, we can get the components in exactly where we want. And again, that's mostly for hip replacements. For knee replacements, what we've been doing here at Holy Cross for the last 8 to 10 months is using a robotic assisted system. We use the ROSA robot system, which is through Zimmer Biomet. That allows us to do several things. And again, robotic surgery is not new. We also have XI robots for general surgery. We have 2 of those as well here at Holy Cross. But what the ROSA robot does is it really it's a more mature technology for robotic assessment of the knee. It allows a preoperative x-ray, which does not have to be a CT scan, can be a plain x-ray. That gets into a 3-dimensional model. We can project exactly where we want the cuts to be to allow room to put in the implants. We can tell exactly where the implants are going to be lined up. It works in 3 dimensions. And the beautiful part of it really is that it works during the surgery. We're actually looking at points, taking measurements as we go, and you can pretty much predict what the effect of a specific cut on a specific bone will be on the rest of the surgery. So I tell people it's kind of like having a a flight simulator in a cockpit. So if you're an airplane pilot, which I am not, but you go in a flight simulator and you have all sorts of ways you can simulate. You can simulate your crosswind and your being overloaded and your whatever. And then when you get in the airplane, as I've heard pilots say, you have to land the plane that you're on. So you don't have the simulator anymore. The robot actually allows you to project a lot of things up to, before, and including and during the surgery. So you can actually say, well, if I made this cut right now, what would it do to this? What would it do to this? What would it do to the other alignment? So it's very much like having a flight simulator that you can just stop, as you're landing the plane, and you can go back in the back and say, okay, let's check this out, and then come back and land the plane. So that'd be great if it was, available in airplanes, but it's not. But the rest of it, it's really, like I said, it's a mature robotic technology. We have it at both hospitals. It's used by many of the surgeons, not every single one of the surgeons. It does require some technical expertise and training, but overall has really been a very important asset for us.
Absolutely, really terrific technology in the service of patient care here at Holy Cross. Laura, I was hoping that you could tell us a little bit about recovery. What does the recovery process look like, both on the day of and then on the longer term?
Sure. So, actually, recovery starts prior to even coming in for surgery, right? The class. We give them exercises. We tell them what they need to do for nutrition and hydration and really preparing the body for surgery. And then when they come in for surgery, day of surgery, you can bet your bottom dollar that they're going to have physical therapy, occupational therapy, day of surgery. So whether it's in the afternoon or early evening, they'll be getting up out of bed as soon as possible. That's evidence-based practice that states that the earlier the mobility, the better the recovery. So we get that started early. Nursing is part of that process as well. So it doesn't necessarily have to be a therapist to get them up and walking first thing. And then we work on that discharge planning. So we've got home care services available for patients and outpatient services. And if they need it, skilled nursing and short-term rehab for patients that absolutely need that as well. So all the resources that you could possibly need, preparing for surgery, having the surgery, and then recovery. And then we follow them after. So we follow up with a 21-day post-op call, see how they're doing, see what their needs are, see if there's any needs to follow up. And I'm always available as a resource as well to patients that they can call and ask questions at any time.
And just one real quick thing. In the last couple of years, there's been a lot of people, particularly people who are on Medicare, have gotten the idea that surgery has to be done as an outpatient, or there's a very strict limit on the whether or not you can be admitted to the hospital. And there have been some significant Medicare rules changes starting in 2019, I think, 18, that allowed outpatient surgery to be done on Medicare patients. It is still absolutely not required that people have their surgery as an outpatient. And actually, from Medicare's perspective, whether you stay one night in a hospital or go home from the hospital the same day or go home from a surgery center the same day, it's really all kind of the same thing. So there's a lot of misunderstandings about, particularly for the Medicare population, what is and is not really, the rule for Medicare. That's typically something we discuss with people in the office. But there are still an option to have surgery done as an outpatient, which we do, and for hips it's about 75%. But people still have a choice what they want to do.
So in our last couple minutes, Laura, I was hoping that you could tell us about the program as our coordinator at Holy Cross Health. What makes the program special, and why should patients consider coming to Holy Cross for their surgery?
Well, first, we have 2 hospitals that offer a joint and spine program. We have Holy Cross Germantown Hospital. We have Holy Cross Silver Spring. We are recognized as a center of distinction with the Joint Commission for our Silver Spring location. Germantown is held to the same standard. That's for our hip and knee replacements. So we were just recertified this past August, which means our standard of care is at the level that the Joint Commission has said it needs to be able to deliver this level of care. We have private rooms for everyone to recover in. So if they do indeed stay overnight, they'll have a private room to recover in, which is great for reduce infection rates. It also is great for patient recovery and satisfaction. It gives the therapist and the nurse room for care in the environment and the patient's room itself as well. And then the resources that we have for even after you've recovered and left us from the hospital. So we have Holy Cross Home Care. We have partnered with Holy Cross Home Care to offer a pre-op home safety assessment for those patients that are preparing for surgery, that are concerned about their home and how they're going to recover in their home after surgery. So that's something that makes us very unique as well.
And if someone's interested in getting a joint replacement with Holy Cross, who can they contact and how can they get started in the process?
Well, certainly they can visit our webpage, and that has a plethora of information. All of our surgeons are posted there as well. They can call our dedicated joint line, which is posted on our website as well, and I'm sure you'll put it up after the presentation. And they can call me directly as well. I'm the coordinator for the program, so I can help direct them in any direction that they need to go for resources.
Absolutely, and we will mention that number and website in a second. So, Dr. Murphy, to wrap up, we've talked a lot about osteoarthritis today, but that's obviously far from all that we and you treat. What are some of the other conditions that you treat, and what are some of the other symptoms that you can help patients with?
Well, orthopedic surgery is a very broad specialty. That's actually one of the things I like about it. It operates on different ages, different sexes, different activity levels. We obviously, most orthopedic surgeons also do a lot of trauma surgery, broken, fracture surgery, broken ankles, broken things like that. There's actually quite a bit of debate in orthopedics, and I believe in other specialties, about getting sort of to a state where we may be a little over specialized. And I like to tell people, Google is actually a very good clinician. It's a good clinical physician. It will tell you about your problem, and you can look up a lot of things, and a lot of them are obscure. But it's not really always a great diagnostician. So to figure out what your problem is, it's still an old-fashioned hands-on thing, and I think it's very helpful to see an orthopedic surgeon who does. And again, I've done thousands of hip and knee replacements, but it's not all I do. It's not exclusively part, all of my practice. And I think it's helpful to see somebody who does a variety of things, because again, it's an occupational hazard for any occupation. When your only tool is a hammer, the world is a nail. To some extent. And I think it's very helpful, and I think it's actually a trend that should be encouraged in medical specialties overall, is avoidance of over-specialization, particularly with tools like the ROSA robot. I don't want to say it makes it so easy that anybody can do it, but it definitely makes it easy, and a lot of you can get absolute quality results, and it's not rocket science. So I think there's actually a trend toward kind of over specializing in medicine in general.
Well, we are about out of time. Dr. Murphy, Laura, thank you so much for joining us today and providing your insights. And thank you to everyone else in Facebook for tuning in today. If we didn't get to your questions, we can provide additional information through our website or our blog, or we can connect with you via our phone or website channels as well. You can connect with us to learn more about our joint services at Holy Cross Health. For more information, you can call 301-754-7774 or visit our website at holycrosshealth.org/joints. Thank you for joining us today on Facebook Live with Holy Cross Health, and we hope to see you again soon.